As Tim said, I'm Dr. Dixon, specialize in orthopedic spine surgery at the Bone and Joint Center. I appreciate you letting me come in and visit with you a little bit today about spinal stenosis. It's something that we see every day, and imagine that it's maybe not quite as common in all of your practices, but hopefully I can teach you a thing or two about it today. I've got 65 slides to go through in 45 minutes, so I'm going to try to bombard you with as much information as I can here.
Actually, it's 30 minutes.
30, okay, even better. Awesome. All right. This is my poor attempt at humor, but I have no disclosures to report. I am going to show you a few examples of instrumentation that we commonly use in the spine, but I won't use any trade names, but I'm not a paid consultant. I don't get any kickbacks or anything like that. So this is just a brief outline here of what we're going to cover today. I'm going to briefly define lumbar spinal stenosis for you, talk a little bit about the epidemiology, go over some basic anatomy, pathoanatomy, talk about the physical exam findings to look for, imaging characteristics, treatment strategies, both non-operative and operative, future technologies, and I have a few cases at the end to go through to make it interesting. So we'll go ahead and dive right in with the anatomy, and just to kind of remind everybody, the anatomy of the spine is, I feel like, pretty basic, but there's a vertebral body, and the vertebral bodies are separated by a disc. The substructure of the disc is there's an outer annulus fibrosus. This is an outer ring of fibrocartilage, and in the center is a nucleus pulposus. It's the outer annulus fibrosus that tears in an annular tear and then allows the nucleus pulposus to kind of protrude through there and cause disc bulges and disc herniations. In terms of bony anatomy, this is going to be important to understand just because when we go through the imaging characteristics and we're talking about why spinal stenosis occurs, we're going to talk a lot about different structures of the bony anatomy. So one of the things I want you to kind of pay attention to is the facet joints here. So there's an inferior articular process from the level above and a superior articular process from the level below, and they kind of sit like shingles on a roof on each other. Those are just like, I always kind of tell my patients in the office, those are just like hip and knee joints. They are articular joints with articular cartilage that, just like a knee or a hip, can wear away as time goes along and be a source of pain generation, and they are intimately involved in the development of stenosis, as we'll find out in a second. So just remember the facet joints. There's another structure as well called the ligamentum flavum. It's a tough ligament that kind of runs right in this area, right in between the bones, and that can thicken and become calcified as we age and as we get older, and the aging process takes its toll on our body, and that contributes to stenosis as well. So this is the transverse process over here. The pedicle is that solid column of bone that connects the posterior elements back here to the anterior vertebral body. And this is kind of just a zoomed in picture of that anatomy and cross section. You can imagine that if the facet joint, which is right here, would enlarge in size as it does as we age, it can decrease the dimensions for this yellow nerve as it exits out of here, and that's going to be one of the dominant features of spinal stenosis, as we'll see in just a second. So I just wanted to kind of remind everybody, I think this is an important map as you're examining patients to remember, because even without seeing any imaging studies, a lot of times if you really listen to what the patient is telling you as far as where their pain is going, have them map that out to you. Ask them exactly where their pain is going. Does it go down the back of your leg or the front of your leg? Does it go to the dorsum of your foot? Does it go past the knee? Those sort of things. And if you really kind of needle them, they will explain it to you. And if you remember this map and remember that L5 comes from the back of the leg and wraps around to the anterolateral aspect of the lower leg and goes into the dorsum of the foot, they'll often tell you exactly what's going on with them. So if you remember this map, it'll kind of help you understand where their problem is without even getting an X-ray or an MRI study. So just wanted to kind of cover a couple things, just kind of show you what the normal landmarks are on a bony X-ray of the spine. So obviously on the left we have an X-ray from the front towards the back. It's called an AP X-ray. What you should always see on these AP X-rays is you should see circular projections on both sides of the spine. If you're missing one, there's a term called a winking owl sign. Sometimes if that is missing, that can clue you into pathology in the spine, such as a tumor or infection or anything like that. So when you're looking at a spine X-ray, look for the circle projections. Look for this little structure right here. That's the spinous process that we saw on that anatomy slide. This is obviously the transverse process. This is actually the facet joint on the AP X-ray, and we talked about the inferior articular process and superior articular process. So these are the structures you want to look for. Specifically for stenosis, when you look at the lateral here, one of the things that can kind of clue you in as to if they have stenosis, especially foraminal, is this is the foramen right here. This is the opening for the nerve as it exits out of the spine to go to the legs. If you don't have a nice kind of gray, oval or circle here, that's a good indication that they have some level of stenosis. That will actually disappear, and I'll show you that on some x-rays here in just a second. So just keep that in the back of your mind. So what does stenosis mean? Just as kind of a broad statement, it's a reduction in the canal dimensions. It can be, as we'll see in a second, it can be central, it can be foraminal in different areas, and I'll define that in a second, but just as a general statement, that's what it means. And it usually results in some sort of neural compression, which then is manifested by pain in the legs, typically. So it can be central, lateral recess, or foraminal. It's usually caused by bony structures such as bone spurs, or the correct term to use is facet osteophytes. We can also see stenosis occur in the setting of spondylolisthesis, when one body wants to slip forward on the other. There are some soft tissue structures that kind of lead to this as well, herniated and bulging discs. I talked about hypertrophy and buckling of the ligamentum flavum and facet cysts. So this is, again, kind of bringing this up, again, the facets can hypertrophy as time goes along, and this is going to cause foraminal stenosis. It can also cause central stenosis and just pinch this shut altogether. And so this is kind of what it looks like in in the sagittal view. You can see that this is the buckling of the ligamentum flavum from the back right here. When they flex forward, as you'll see in physical exam and interview findings, you'll see that actually goes away. They're actually indirectly decompressing their spinal canal, so they feel better when they're flexed forward than they do when they're standing upright or extended, because that ligamentum flavum is able to stretch out, whereas here it's infolded and buckled and will cause neural compression. So there's a few different ways to classify this. There was a landmark study back in 1976 by Wiltsey and his associates that was published and is commonly cited in the literature. There's acquired and congenital, basically, are the two broad categories. The most common is going to be degenerative. There's also post-surgical, traumatic. Post-surgical is usually going to be related to adjacent segment disease after a fusion. Traumatic might be, obviously, after a car accident if they have a traumatic injury of the spinal canal. Inflammatory, we often see that in ankylosing spondylitis patients. Their ligamentum and ligaments become calcified and hypertrophied. Congenital stenosis, that's going to be a little bit rare. There are people who have congenital stenosis even though they don't have any syndromes. The most common, I guess, example of congenital stenosis in achondroplastic patients. They typically have short pedicles and therefore have a smaller dimension in their canal. This is typically defined on an MRI, AP diameter on cross-section of less than 10 millimeters. And normal is typically 13 millimeters or greater. That's how it's typically defined. So there's one other classification system that sometimes we refer to, you'll hear us talk about. I already kind of mentioned it: central, lateral recess, foraminal, extraforaminal. This is kind of a picture that depicts where those zones are. So, obviously part of half of the spine is removed here, kind of showing you where these are at. So the central canal is kind of the largest area, and then the lateral recess, which is poorly understood, it's kind of at the lateral margin of the thecal sac there, out to the medial aspect of the pedicle right here. That's considered the lateral recess. And the reason why that's important is because in terms of your pathology on exam, if you have lateral recess stenosis, let's say at L4-5, it's going to affect the traversing nerve root at that level. So at that disc space, it's actually the L5 nerve root that gets affected by lateral recess stenosis, not the exiting nerve root at that level. So that's just something to think about. There's also foraminal stenosis, which is just like it sounds. It's right below the pedicle here. That's usually going to be disc pathology. That's going to give you that level of stenosis. And the same applies for lateral, far lateral, or extraforaminal, which is just like it sounds. It's after the nerve is completely exited. So you'll hear people use these terms. This is kind of what it means. It's just descriptive based off the anatomy. That's something to keep in mind. This is called central stenosis that this little girl is experiencing right here. Spinal stenosis is pretty common in the population. About 9.3% of the general population has spinal stenosis. There's a landmark study that we're going to talk about in just a second called the SPORT trial. It's the most important really study that we have in spine that kind of defines who we should treat with for spinal stenosis and how we should treat them. But it kind of defined for us that most people with spinal stenosis are usually seen in their 6th or 7th decades of life, so it's usually towards to the latter half of their life. The mean age that they found in their study was 64.6 years of age is typically when they started seeing these people present. It is the most common reason for spine surgery in patients greater than 65 years of age. Males are more common than females typically. The most common levels are L4-5 and L5-S1. This is similar to the cervical spine. The most common levels to have stenosis in the cervical spine are at the bottom 2 levels, C5, C6, and C6, C7. And why is that? It's because that's where all the range of motion is in your spine. That's where all the force is kind of concentrated. So that's where all the pathology typically starts. So the bottom levels are typically affected. So what physical exam findings are you going to see in your patients with spinal stenosis in your office? Making the diagnosis, quite frankly, is usually made just based off of interview and physical exam findings. You usually confirm the diagnosis with imaging. That's when you take the next step and get x-rays and MRI. So what are you going to hear and what are you going to see? Back pain is a very common complaint, but I think the description of that back pain is important. You can kind of refine it a little bit. I usually, one thing I was taught in my training that I thought has served me pretty well up to this point is understanding that there is referred buttock pain that is pretty typical spinal stenosis, meaning I usually use the belt line as kind of my cutoff to kind of decide, is this a facet-mediated low back pain, or is this a discogenic or spinal stenosis type referred pain from the back? And so if you kind of use the belt line as your equator, I think that kind of defines it pretty well for you. So usually back pain that's always above the belt line, and at least in my opinion, is usually related to the facet joints, and anything that's below the belt line is typically either referred from the spine or is potentially sacroiliac joint related. There's 2 different types of claudication. So in central stenosis, you're going to affect multiple different nerves, and that's going to lead you to what's called neurogenic claudication. And this is the person that you see when you're at Target or wherever, and they're leaning over the shopping cart and they're walking, but if you took that shopping cart away and they had to walk around the store, they wouldn't be able to do that. They can't walk as far as they'd like to. Their common complaints are I feel this kind of vague pain in my buttocks, posterior thighs, sometimes calves. I want to, when I stand up and stand for extended periods of time, I have to sit. I can't stand for any longer than 5 minutes. When I'm walking through the supermarket, I have to stop frequently, sit down. Those individuals usually have some level of neurogenic claudication. You do have to rule out vascular causes because that's another common reason for these kind of complaints. So you need to look at their legs, see if they have hair on their legs or not, check their pulses, that sort of stuff. So just keep that in the back of your mind. But that's typically what you're going to hear from the lumbar spinal stenosis patient who has claudication. Again, depending on if it's central, lateral recess, or foraminal, if it's more foraminal or lateral recess, they may come in more with a true radiculopathy where it's not really affecting both sides, but it's more pain shooting down the back of their leg, sciatica down to their foot. And they'll come in with varied complaints of that. And again, you just kind of have to really pay attention to where they're describing that their pain is going. Remember your dermatomes and myotome maps. Remember that quad weakness is going to be, obviously L3-4, that tib ant or ankle dorsiflexion is going to be more of an L4-5 issue. So just kind of remember those things because it'll clue you in. Your patellar and Achilles reflexes can be asymmetric. Remember your grading system, but basically what you're looking for is depressed reflexes on one side that correlate with your imaging. There are some specific physical exam findings that are described in the literature, but they're all pretty non-sensitive. They more kind of go along with the interview. Kemp sign is extension-based and kind of lateral bend movement that recreates back pain and pain down the legs. Straight leg raise, that's what SLR is. That's a nerve root tension sign that I'm sure most of you are familiar with. You raise, it's actually more sensitive if they're laying down instead of sitting, so you want to lay them down for this exam. Lift their leg and then dorsiflex their foot and document at what level they start having recreation of pain down their leg. That's a positive straight leg raise sign. And then Valsalva maneuver, that's just obviously simulating a bearing down movement and seeing if they have recreation of pain. So, usually start with x-rays and go to an MRI, sometimes a CT or CT myelogram in special situations. At least in my office, x-rays are usually the first line of imaging that we typically get. And I think it's an important thing to get in this day and age. There has been a little bit better understanding that spondylolisthesis can be missed if you just get an MRI. So the reason why x-rays are an important study is because you're weight bearing on an x-ray. So you're standing up, and this can actually demonstrate for you a listhesis on the standing lateral x-ray. So it's an important study to get, because if you just go straight to an MRI, they lay down in an MRI scanner or a CAT scanner, and then you can miss their spondylolisthesis. And the presence of that mobile spondylolisthesis affects what type of treatment you're going to give the patient. So you need to get upright x-rays, especially if you're going to consider them for surgery at some point. What do you see on the x-rays? Well, as you'll see in a second, you see end plate sclerosis, you'll see hypertrophy of those facets that we talked about, plus or minus spondylolisthesis and disc space narrowing. These are common things that you'll see. And occasionally we'll get obliques, so if you're looking for a special type of spondylolisthesis, which is called an isthmic spondylolisthesis, which is a PARS defect, then you'll get an oblique x-ray to look for that. So this is an example of standing AP and lateral x-rays that we'd like to get here. And on that AP x-ray, you can see that they have a little bit of degenerative scoliosis there, but globally they're balanced in their lumbar spine. And you see all the circle projections and the other anatomical landmarks that we look for. I think the biggest findings are seen on the lateral x-ray, where you see kind of right in these areas. And I'm sorry, I know some of you can't see where I'm pointing, I apologize for that, but you can see that there is not a tall rectangular space in between these bones. That's evidence of degenerative disc disease, disc space collapse, especially at L5S1, L4-5, a little less at L3-4. If you look for the foramen, remember we talked about that little gray circle, it's a little more prominent at this level, but you see how that kind of goes away at these other levels. So this patient has stenosis, and you can actually see that on the x-ray here. And you can see a lot of facet hypertrophy that has developed at these bottom few levels in their spine as well. So these are called flexion extension x-rays. I'll get these often as well, just to see if there's any dynamic instability, meaning do they have a slip in their spine when we go from flexion to extension. Interesting finding on this one is you can see that there's actually air that you didn't see on the first lateral in the disc space. Again, air in the disc space means that there's really no disc material. So they could have a lot of discogenic low back pain related to that. CT and CT myelogram. CT scan in isolation for spinal stenosis is somewhat limited in its ability to diagnose it, but you can see kind of soft tissue shadows, as we'll see in a second, that point to this, but it's not as sensitive as an MRI. So if the patient is able to have an MRI, the preferred study is still an MRI, but a CT in the absence of an MRI can sometimes be a pretty valuable study. And if you really need to see just how tight their spinal canal is without an MRI, you can add a myelogram as well, where the interventional radiologist actually injects dye into the thecal sac, and that kind of, you're looking for filling defects. Then if there's a tight canal, you'll actually not see any contrast in that area, and that indicates that it's stenotic. So we'll often do that in situations where patients have pacemakers, bone stimulators, pain pumps, or sometimes if there's an abundant amount of prior postoperative changes in hardware and a lot of metal artifact on MRI, we can get a CT myelogram to kind of define that better for us. So this is an example of a CT scan. I apologize I didn't have a chance to find a myelogram to put in here, but a CT scan here. This patient obviously has a L4-5 spondylolisthesis. You can see that where the back of this bone doesn't quite line up with the back of that bone. That's an example of a spondylolisthesis right there. They have vacuum disc phenomenon. That's what this is called up here. When you have air in the disc space and it's black, that's called vacuum disc phenomenon. You can see the end plate sclerosis over here on the axial or cross-sectional image. Over here you can see air in the facet joints right here, and you can see that there's a bunch of calcified ligamentum. The nerve sac or thecal sac is actually just getting smashed right here between calcified disc right here and all this calcified ligamentum. So this patient's really, really tight right here. Okay? So MRI, like I said, is the most sensitive study for spinal stenosis. Typically, I like to look at T2 images. So when you look at an MRI, there's going to be T1 and T2 images. And I like to bring a sagittal cut up, as I'll show you in a second, a sagittal cut right next to an axial cut, put lines on them so I know where I'm at, and know exactly what level I'm looking at, which side I'm looking at. And one thing to remember is the CSF, which is the fluid around the nerves, is bright on a T2 image. So if they have spinal stenosis, that T2 sequence goes away and it becomes black or gray, and that's going to indicate that there is stenosis. So one other thing I want to mention before I show you examples of that is This is an important study that was published at Emory University by Scott Bowden, and it talks about just if I went out and took MRIs of 20 people's back out there, they don't have any symptoms at all, we just get MRIs. There's a pretty good chance, depending on their age, that you're going to have some sort of abnormality on that. And the only reason why I bring that up is because we have patients all the time who come into our office and they have an MRI report. And they hand it to us and they say, "Doc, look at this. There's mild stenosis here at L4-5, and there's disc desiccation, and there's all these bad terms on there." And it really doesn't mean anything if there's not concordant symptoms. Does that make sense? So you can have all these, you can have severe stenosis in your back, but if you have right-sided leg pain and the MRI shows it's on the left, that doesn't mean anything. You know what I mean? That doesn't make sense. I'm not going to go do surgery on someone who has left-sided MRI findings but right-sided leg pain. You know, it has to be concordant, so that's the point I'm just trying to make with this slide. So this is an example of MRI characteristics. These are two T2 images, a terrible looking spine here, but what it's showing you is you can even see what we call modic changes, which is swelling in the bone, hyperintensity. That's usually seen with severe degenerative disc disease. You can see there's almost no disc left. There's bulging of the disc. The white signal right here is going to be the CSF fluid right there. You see it go away at several levels, so this is a very stenotic spine. And here again, you can see that there's almost no white signal. Normally we should see kind of a round white signal, which I'll show on the next slide. This one doesn't have it. And over here, they're trying to show you foraminal stenosis, which I think is better demonstrated on this slide. So if you look here, here's a gray dot, or if you look, I don't know if you guys can see over here, but there's a gray dot here with white signal around it. You come down to L4-5 and there's almost no white signal. So that's an example of foraminal stenosis. You have to look on the MRI on the sagittal cut. Over here, this is what it should look like when it's normal. You see that there's a nice round white nerve sac, gray dots inside are the nerves. This is a nerve that's exiting, that's a nerve that's exiting, that's wide open. There is a grading scale based off the amount of CSF signal. So again, this is kind of what I was just referring to. There's, this is obviously at the far end of severe, and this is the normal right here, and the gradations in between. I don't even know what to say about this. This just seems like a bad idea. I don't know what you guys think, but I think you guys have this. Everybody gets a copy of these slides, right? Yeah, okay, so you guys you can look through this, but the bottom line is this is an algorithm that kind of goes through potentially to guide you with treatment. I think the bottom line is everybody should get some level of non-operative treatment right away. That's kind of the first step in all situations. The exceptions would be people who present to your office with Cauda-Equina syndrome or severe neurologic deficits. Those people I always tell people, if you have constant patches of numbness on your skin, weakness in a muscle group, obviously bladder bowel dysfunction, those are people that need surgery right away, and you skip this step. But almost everyone else should get some level of non-operative treatment, and they always do when they come to our office. So there's kind of like a stepwise progression and a ladder, so to speak. The first step on the ladder is medications. And what do I mean by that? It's usually anti-inflammatories, assuming that their creatinine and things like that are normal and they don't have GERD and that sort of thing. But we do try to do anti-inflammatories, anything from ibuprofen and naproxen over the counter to things such as COX-2 inhibitors like Mobic and Celebrex, or celecoxib and meloxicam. You can also do Relafin. So you know, those are your anti-inflammatory options. Keeping the level of anti-inflammatory level in your blood so that the inflammation can't flare is kind of the idea behind that. You shouldn't do narcotics, muscle relaxers and steroids. There's certain situations that you might, but this is highly discouraged. Anti-inflammatory creams and gels are sometimes useful, like Voltaren gel, sometimes can be a useful adjunct to this. Chiropractic treatments, manipulation, acupuncture. The literature's not good to support this. There's some weak evidence out there to support chronic axial back pain getting relieved with chiropractic treatments, but otherwise it's usually short-term relief, at least in my opinion. Physical therapy, for me, this includes, in most cases, obviously there's exceptions, but includes iontophoresis, e-stim, traction therapies. I like to, try to throw the whole thing at them, all the modalities if possible. I like to avoid extension-based exercises for all the reasons that we just talked about. Extension typically makes these people worse. But Kevin will go through all this with you guys. He's the expert. So injection therapies, I think that's going to get covered by Lori. But I'll just say one thing about injection therapies. I do like to do the transforaminal varieties. of injections as much as I possibly can, because it's a more specific injection, and it's better at predicting how these people are going to do with surgery. An interlaminar epidural steroid injection, while technically easier and sometimes gratifying in the short term, is a much more generalized injection. Is difficult to really kind of help us predict how these people will do with surgery. So the transforaminal injections are really helpful, and the medial branch block injections are more for facet pain. So there's a couple different treatments for operative treatment: decompression alone or decompression infusion. Laminectomy and laminoforaminotomy are your two decompressive options. And then if you do a decompression infusion together, there's a bunch of different alphabet soups that I'll go through. Just want to mention real quick the sports study. This is, again, a very important study that was published about 8 years ago that compared operative and non-operative patients. It showed superiority in all endpoints out to 8 years for surgical treatment for both spinal stenosis and spondylolisthesis. So for correctly selected patients, these surgeries do a lot of good for these patients. Laminectomy, laminoforaminotomy, what does that mean? I'll explain in a second, but the bottom line is what I tell my patients is with these surgeries, your goal is leg pain relief. It will get rid of your leg pain. It will do nothing for your back pain. So they need to know that going in. If they're going to get a laminectomy or a laminoforaminotomy, it's probably not going to help their back pain because you haven't done anything to their facets. You've left the facets there, you've decompressed their spinal canal, their arthritic facets still rub against each other, so typically they still have some level of back pain. If you're wanting back pain relief, you at least have to consider a fusion. Laminectomy, you're removing the entire central midline structures. Laminoforaminotomy, which is a technique that we try to utilize as much as possible, you're really leaving the central midline structures and decompressing the lateral recess and foramen, and you can kind of indirectly decompress the central canal. There's some biomechanical studies to support that as having less back pain after that procedure. So this is kind of an example of a laminectomy. The central midline structures have been removed. This is a laminoforaminotomy. You can see that the central structures have been preserved. Going on to lumbar fusion, the traditional open lumbar fusion is something we're probably all familiar with. You're basically usually combining a laminectomy and then also putting in pedicle screws to kind of fuse the spine and stabilize the spine and get rid of that facet-mediated pain. You can combine it with a device that goes in between the vertebral bodies in some cases. But the biggest problem with this, I mean, it's time tested, but it's very invasive. You have to dissect the soft tissues all the way out over the transverse processes of the spine. So this is an example of a traditional lumbar fusion that was done. You can see that there's kind of a gray line in the midline. That's going to be where their laminectomy defects are. And if you look real closely on the lateral aspect of those screws, you can see that there's kind of a haziness. That's the fusion gutter that we put the bone graft into. And so that's what you're looking for in follow-up x-rays, is looking for evidence of that kind of haziness in the lateral gutters. Here's your alphabet soup. These are called interbody fusion techniques. We combine them sometimes with the traditional open fusion. They're either posterior based or going from the lateral aspect, almost the abdomen, and then straight from the abdomen anterior. It just depends on where you're inserting these devices in between the vertebral bodies from. So if it's posterior, you can do a T-lift, which is through the foramen, transforaminal lumbar interbody fusion, or a PLIF, which is posterior lumbar interbody fusion. You're kind of going through the lateral recess instead of the foramen. The lateral fusion techniques, you're going through the back of the abdomen essentially and docking onto the psoas muscle and going through the psoas muscle into the spine. And it's technically an anterior procedure, and the advantage to going and being able to get these devices is that we're able to recreate the lordosis of the spine, which is very advantageous long term and to decrease adjacent segment disease. So the way that we do that is with lateral and anterior procedures. So this is an example of a PLIF versus a T-lift. You can see the arrow kind of indicating you have less risk to your neurologic structures with a T-lift rather than a PLIF. And this is an example of the decompression where you've removed the facets entirely and you get access to that disc space. This is an example of one of our T-lifts that we've done here recently. We use a device that is a banana-shaped cage, and you have to kind of steer it into the disc space and then get it as far to the front as possible, and then it actually expands intraoperatively, and that allows us to recreate that lordotic curve. We found over the years that reestablishing that normal lordotic curve is very important to their long-term success. This is a PLIF because you're kind of going through the midline structures. You're using two cages. They're a little bit smaller. You don't get quite as much lordosis. You might do that in situations where it's just really tight or you can't access the L5-S1 disc space because of prior surgery, which is what we happen to do here. This is an example of an A-lift. This is going through the abdomen, usually with the help of a general surgeon or a vascular surgeon to retract the aorta and vascular structures. You clean out the disc space from the front. You're able to get a very large cage, which increases your surface area for fusion, which is advantageous, and it also does a lot more correcting than the T-lift cages that we can do. You can just use like the screw structure that you have there, or you back them up with pedicle screws from the back. This is an example of one that we did. An A-lift, it doesn't have screws, but it has flanges biomechanically. That's just as sound, and then we went to the back and decompressed L4-5 and L5-S1. That's an A-lift. This is a lateral interbody. We do these. You're going through the side and down through the psoas muscle. Cages can expand as well as what you see right here, and this is a device that we like to use. This is an example on x-ray of that lateral interbody fusion. You can see an AP x-ray. We did 2 levels in this case, and then you can see a lateral x-ray, kind of what it looks like looking through our retractor right there. It's considered a minimally invasive operation, which is nice. O-lift, this is a little bit different than going through the psoas, and it's a nice new technique. I need to move fast. Sorry, guys. I'm out of time already. So. Just real quickly, these are things that have come and gone. Interspinous devices, they don't do anything. In fact, we're always revising them, so if you hear anybody talking about them, don't let them do it. It's just going to end up with a revision. There's a few different things. The reason why we're looking for new technologies is to avoid adjacent segment disease. There's good literature out there to say with fusions, the disadvantage of them is every 10 years, about 30% of them need to be added on and fused. So we're looking at lumbar disc replacement, flexible rods to maintain motion at the site, or facet replacement. This is an example of lumbar disc replacements, and this is kind of what they look like intraoperatively. The literature is just not quite there yet to start offering that in mass to the public, but we're hoping that it comes soon. Flexible rods, so instead of having that stiff rod, there's a transition segment like you see here. This is what a facet replacement looks like. We're hoping that becomes a little more promising, and that says it all. Real quick, and then I'll be done here. We can skip the cases. When to refer to a surgeon. Again, cauda equina, bladder and bowel symptoms. Obviously, I think it kind of goes without saying. Neurodeficits, foot drop, constant areas of numbness, weakness, asymmetric reflexes. You should probably get them to us so that we can start following them and get them plugged in. Failure of non-operative care, and if you ever have any questions, just give us a call. I mean, we're always happy to answer questions and phone calls from people out in the area. So I guess I'll stop there. We can go over cases some other time. So thanks. Any questions?